Hi, I'm Dr. Henderson McGinnis. I have a patient that I can't intubate and I can't ventilate. At this point, I've decided to proceed to a surgical airway. I will palpate the landmarks finding the cricothyroid membrane. I will then make a vertical incision through the soft tissue. I'll then make a horizontal incision through the cricothyroid membrane. I will then turn the scalpel around, dilate the space, and then I will direct an endotracheal tube in towards the patient's feet.
Dr. McGinnis's demonstration of a simple cricothyroidotomy took less than 30 seconds. It's a procedure that must be done with extreme urgency and is an essential skill for every emergency physician. I'm David Klein, an emergency physician and an editor for Tintinelli's Emergency Medicine. Cricothyrotomy, or cricothyroidotomy, is a commonly recommended surgical airway maneuver. The inability to orally tracheally intubate a patient is the prime indication for cricothyrotomy. In general, oral tracheal intubation using rapid sequence induction techniques should be attempted prior to considering cricothyrotomy. Immediate cricothyrotomy should be considered for ongoing bronchial pulmonary hemorrhage or massive midface trauma.
Ideally, preset sterile procedure trays containing the necessary items should be ready for use when emergently needed. Items to include are shown here: a scalpel with a number 10 blade, a scalpel with a number 11 blade, a tracheal dilator, a mosquito or Kelly clamp, a tracheal hook, a tracheostomy tube or a number 6 endotracheal tube, syringes and needles for local anesthetic injection. These are the anatomical landmarks of the larynx. The larynx must be immobilized so that the landmarks are distinguishable. The red dotted line is the incision site for the cricothyrotomy. As with all open procedures, the physician should use sterile gloves as part of personal protective equipment. The physician, at the level of the patient's head, locates the cricoid ring. Place the index finger at the sternal notch and palpate cephalad until the first rigid structure is felt. This is the cricoid ring. Roll the index finger 1 finger breadth above to locate the hollow between the cricoid and thyroid cartilages, the cricothyroid membrane. Using a syringe with a 25 gauge needle, infiltrate the skin and the underlying cricothyroid membrane with the 1% lidocaine in a line across the membrane while steadying the thyroid cartilage with the left hand. Omit this step if complete airway obstruction is present. Using the thumb and the middle finger of the non-dominant hand, stabilize the cricoid and thyroid cartilages in preparation for initiating the procedure. Use the scalpel and the number 10 blade to make a vertical incision in the midline between the two cartilages. The length of the incision should be as much as 3 centimeters in length. The depth of the incision should go through the skin and the subcutaneous tissues. The structures are superficial, and care should be taken not to incise deeper, because this may result in damage to the cartilages or the vascular structures. Repalpate the cricothyroid membrane through the incision.
Typically, when looking directly into the incision, the operator will see the pretracheal fascia overlying the membrane as shown here, which may be further obscured by blood. Therefore, the cricothyroid membrane is chiefly identified by palpation.
With the scalpel and the number 11 blade positioned horizontally, perforate the cricothyroid membrane so that the blade goes in approximately half its length. The larynx should be stabilized by inserting the tracheal hook into the cricothyroid space. Retract upward upon the inferior edge of the thyroid cartilage. An assistant should hold the hook after it is placed. A dilator should be inserted through the opening in the cricothyroid membrane to widen the space. If a dilator is not available, use a mosquito or Kelly clamp in the non-dominant hand with the point downward. Insert the clamp into the incision and spread to maintain the opening. You can also use a glove digit to widen the opening. Place the tracheostomy tube, or use a number 6 endotracheal tube, place into the opening and direct it caudally. If using a tracheostomy tube, you will need to remove the obturator and insert the tracheostomy tube to ventilate. If using an endotracheal tube, take special care that the tube is inserted no more than 2 to 3 centimeters. Otherwise, the tube will slip down the right mainstem bronchus. Connect to a bag valve mask device for ventilation. Check for bilateral breath sounds.
Surgical cricothyrotomy will be implemented infrequently in the typical emergency medicine practice. However, when needed, there is no time to spare. Familiarity with the techniques described is an essential skill to the emergency medicine specialist.